Good afternoon, everyone. I'm Michelle Quesada here with WPTV, and I'm joined this afternoon by Dr. Yong Sing da Silva. He is the Medical Director of Pediatric Critical Care at Palms West Hospital. Dr. da Silva, thank you so much for joining me. We are talking today about the kids in the 5 to 11 age range and the COVID-19 vaccine. We know that just as of yesterday, the Food and Drug Administration Advisory Panel voted to recommend the child dose for Pfizer's COVID-19 vaccine for those 5 to 11. A couple weeks ago, we talked about this, and now we're here. We're at this point. So, Dr. da Silva, just real quick, I wanted you to just kind of introduce yourself. I know, obviously, the vaccine has been a huge component of what parents have been talking about, trying to keep their kids safe with COVID-19.
Yeah, so my background is I'm a board certified and fellowship trained pediatrician and pediatric ICU doctor. Again, as you mentioned, I'm the medical director of the pediatric ICU and the pediatric floors over at Palms West Hospital. And, we're just now starting to catch our breaths a little bit from the summer wave of Delta-driven coronavirus cases in the pediatric population, where we saw all ranges of children becoming quite sick, requiring ICU level care, both because of acute COVID pneumonias and the kind of respiratory complications that we've come to unfortunately know well from experience in the adult population, but also the post-COVID inflammatory syndrome that typically affects the heart and can be quite severe. So again, we're just starting to catch our breaths from that onslaught. So the news of the vaccine's emergency use, impending emergency use approval is really positive for us.
And I just want to remind all viewers joining in, thank you for joining us this afternoon to talk about this. And if you have any questions, please feel free to put those in the comments and we'll try to get to all your questions. Doctor, you mentioned, that you just came off, you're just kind of in a slower phase now of seeing those illnesses come into the pediatric unit with COVID-19. Can you talk a little bit about the age ranges of kids that you were seeing come in really sick from COVID or any complications from COVID?
Yeah, it's really been all ages. I would say the youngest we've had has been a month old, and up to the oldest adolescents. I'll say that what's been striking is the lack of significant medical comorbidities in a lot of patients who were affected and kids who got really sick, particularly in the MISC population, which is the multisystem inflammatory syndrome after COVID. So those patients were typically quite healthy and actually had asymptomatic or very mild cases of COVID initially. With respect to the severe COVID pneumonias with the low oxygen levels and the need for advanced respiratory support, those patients, again, spanned age ranges. I think some of the sickest also had a comorbidity of obesity and higher BMIs. Some had asthma, some did not. But again, there were a number of really previously healthy children who came in with severe hypoxia to our unit.
We saw similarities between what gets adults really sick, the comorbidities with obesity, respiratory issues. We saw that parallel in children as well.
Definitely. Yep. And kids with asthma, it complicated acute severe COVID pneumonia as a trigger for asthma is obviously a bad combination. So there was that. We had some populations of children with sickle cell disease who were sick as well. And again, a significant proportion of the patients were previously healthy, completely fine. You would not have predicted that these children would have gotten really severe pulmonary COVID.
And, obviously, we're talking about the Pfizer vaccine becoming available to kids 5 up to 11, possibly the first doses in November. Doctor, can you talk a little bit about, obviously, this is optional. Parents are going to decide if they want their child to receive this vaccine or not. What was the feedback you got from parents of patients that you worked with at the hospital who became sick? Did they have any sense of, yes, as soon as the vaccine comes out, I want to get it for my child, or no, now that they've had COVID, I'd rather wait a while and see how their natural immunity works?
Yeah, so I'll say if the children were sick enough to be in the ICU because of severe acute COVID, it was really too late for a vaccine at that point for this, for that duration of illness. But I think that I'll say that mirroring the adult sort of characteristics of hospitalized patients, I would say that all of the patients over 12, so all of our pediatric age but vaccine eligible patients who had severe COVID pneumonias were unvaccinated. So we did not see any patients who had been vaccinated who came in with a severe COVID pneumonia requiring inpatient or ICU level care.
Interesting. And, there are a lot of questions surrounding how is this vaccine for the 5 to 11-year-olds any different than what we're seeing 12 and up? We know that the dose is going to be lower. Can you talk a little bit about the differences we might see in those vaccines for younger kids?
Sure. So, I have the same information as the general public at this point. But yeah, what I've seen, it's about a third the dose of what's been given to our adolescent and adult aged populations. It's going to be a series of 2 doses. Separated by 21 days. And it seems that, in the 2,000 or so patients that were studied with the initial trial that Pfizer did, the risk of adverse events were very low. It was below 2 in 1,000, and they chalked those up to non-vaccine related issues, actually. So, it seems to be quite safe with this initial population. But again, most vaccines are quite safe. And even the myocarditis in the adult population, which I think got a lot of press, probably more press than it deserved relative to the rates, which were quite low, at most about 1 in 10,000 vaccinated patients. So that remains to be seen. I think the original Pfizer study, of the 2,000 patients was not really powered enough to detect significant myocarditis rates or lack of significant myocarditis rates. So that question still remains to be answered. That said, in the adolescent population who got COVID, the clear sort of phenotype arose for patients who would have gotten the post-COVID vaccine myocarditis. Those patients were typically male, typically older adolescents, which is the most common population for any kind of myocarditis. The myocarditis clinical course itself was very self-limited. In most cases, the patients just needed a dose or 2 of Motrin, and their symptoms went away. The cardiac enzymes trended down. Again, none of these patients required any kind of medication to keep their blood pressure up or any kind of advanced life support therapies. If they got hospitalized at all, it was often brief, and the illness was very self-limited.
And doctor, what information is out there right now on the other trials for vaccines for younger kids? I know Moderna's trial started sometime this summer as well for kids 5 to 11, I believe, or 6 to 11. And where are the other trials? I know a lot of people are trying to see what other vaccines come behind this Pfizer approval.
Yeah, from what I've heard, the safety profile seems to be similarly excellent, but I don't have any additional data that the general public hasn't been able to review yet. So I don't know. I suspect it to be fairly safe, but again, I wouldn't make any decisions or make any recommendations until I've seen the data myself.
Now, with this vaccine, are there any children, any types of history or immune issues with the children 5 to 11 that you would recommend to a parent? Maybe you shouldn't get the vaccine.
I would really, again, I'm an inpatient, I'm an ICU doctor. I would really go I would suggest that parents discuss this question with their primary pediatrician. I think there are select populations for whom the vaccine may not be a great idea, but I think across the board, as a general statement, I think the vaccines are very well tolerated. And I think in absence of some sort of anaphylaxis to a prior dose of COVID vaccine or known anaphylaxis to a component of the vaccine, I think the vaccine should generally, and again, this is a general statement, be quite safe across the board. But I think if parents have individual concerns, I think that the best person to talk to about that would be your child's primary care doctor, who knows your child best.
And Dr. Da Silva, you mentioned, that with the Delta variant, you saw more severe cases of COVID-19 in children than what we saw at the beginning of the pandemic. Because initially, we saw that the cases were very mild among children. Many times they were asymptomatic. Have you seen in children any of the long hauler effects that we've seen in some adults?
Yeah, that's a great question. And I think that's one of the biggest questions we have about pediatric COVID is what the long haul rates are. What is, if any, the neurocognitive impact? And are there any lasting deficits, after a month, 3 months, 6 months, 1 year out? I think the numbers really need better study. I think on average, it's probably about 15% of cases. But again, it's difficult to say. I don't think we have the data to really say accurately now. But it is a concern in the peds population. Again, my day job as an ICU doctor, we don't typically see the patients after discharge, so I wouldn't be able to tell you from personal experience. I just know what's quoted in the literature that's been the studies that have been done so far.
Of course. And, there are a lot of questions usually about natural immunity. I've seen a couple comments already on here talking about they prefer natural immunity over the vaccine. Can you talk a little bit about that and, why is natural immunity enough to protect you from this virus in long term?
Yeah, I'll say, the natural immune response is potent. I don't know, and I don't think anyone knows whether it's sufficient and how long it lasts. I think antibody titers are one index of how well your immune system is going to respond to a threat and a novel threat like the coronavirus. But I don't think we can say for sure whether natural immunity is sufficient, nor how long it lasts. So I think the availability of a safe and known to be effective vaccine that can produce a predictable, robust immune response that lasts for hopefully at least 6 months, as we've seen in the adult population, I think would be a welcome effort to getting this pandemic under control and getting our kids back to normal.
Tina Marie has a really interesting question. I haven't seen this before. Will the option of smaller needles or a patch be an option instead of the regular shot for younger kids? That's interesting to me, seeing as how, once we go from 5 to 11, it's going to obviously go younger than that. Is that something you've read about, doctor?
I'm not sure yet. I know that the volume is certainly going to be smaller. I am not sure about different delivery systems, smaller needles. I think it would be probably logical that would be an option, but I'm not sure how it's been studied so far. But yeah, it's certainly logical. I think the needle size. Personally, I wouldn't be too concerned about needle size in delivering the vaccine, but I understand why it would be a concern for parents whose children are going to receive a number of vaccinations over the course of their young adult life.
And Cindy also has a question. With 11-year-olds that get the 30% strength dose of the vaccine, do they need to get some type of booster when they turn 12, since then, the dose at 11 is less than the dose at 12?
Yeah, that's a really good question. I don't know. I'm not sure that anyone knows at this point. I will say that there's some thought that the full adult dose that were used for the older adolescents, the 12 and up, may have been more than what was required, and that a smaller dose may have been sufficient to prime the immune system and generate the antibody response that would confer protection from hospitalization and death, from severe disease. So likely a smaller dose would have produced a similar effect, but again, we don't know. So what the booster schedule will look like after the child gets to 12 years and up, we don't know yet. There's a decent chance that the dose that the patient got at age 11 is going to be sufficient. But again, I'm sorry to say, but we just don't know.
A lot of people are talking about how the vaccine doesn't keep you from getting sick. And obviously we know that it does not prevent you from getting COVID. Can you talk about the effects and the benefits of what the vaccine does do once you receive it?
Yeah, absolutely. I mean, the real point in vaccinating and the illnesses we generally vaccinate against in pediatrics and in all medicine are illnesses that cause severe illness. So hospitalization, death, some kind of adverse long-term neurologic or pulmonary or cardiac sequelae or consequences of illness after the critical illness phase has subsided. So I would consider COVID exactly the kind of disease that we would want to vaccinate against, particularly with such a safe vaccine. I think we just got data sort of real world data and how well the Pfizer vaccine protects against hospitalization and death in the adolescent population who received it from June to September. Again, and this was mostly Delta variant, and it's extraordinarily effective. I think in that population, only 3% of the hospitalized COVID cases had been vaccinated. So it confers a more than 90% protection against severe hospitalization, severe illness, hospitalization, and death, which is really what you want a vaccine to accomplish.
A lot of people have also asked about the younger children, below 5 years old, including babies. I know that, I don't know if the studies have started for that yet. Is that something that you see forthcoming now after this next group gets approval? I mean, have there been any discussions about extending the vaccine age?
Yeah, for sure. I think that trials are underway. I think that there's definitely interest amongst pediatricians and amongst public health officials in getting patients vaccinated across the board. Again, in personal experience, I've seen patients as young as a month and 2 months get very sick from COVID. So while the rates and the chances of severe illness are less than adults, it's in no way a completely benign disease for even our youngest patients.
And have you seen kids that young, 5 and under, become severely sick with COVID? Or are they more mild cases? What do you normally see in that age group?
Well, again, my bias as an ICU doctor, so all I see are the sick cases. So yeah, absolutely. I've seen, again, patients who needed breathing tubes, patients who needed advanced levels of respiratory and hemodynamic support. Again, it's a younger kind of school age population that's most at risk for the MISC, the post-COVID inflammatory syndrome that mostly affects the heart and can cause life-threatening heart inflammation and heart dysfunction. And school age children are the real major population that we're seeing there.
Are there any related illnesses that you're seeing that come off of COVID-19? Like, I've heard a lot of parents who said that their children went to the hospital because of an appendix issue, and then they tested them and they were positive for COVID-19, but it wasn't really like concrete evidence that that's what caused it or what happened. But I'm just curious to see what the correlation is between the appendix issues and COVID.
It's hard to say. Again, I'm not sure that we know that there's a link. I mean, appendicitis is very common, and so is asymptomatic COVID infections and mildly symptomatic COVID infections. So it's hard to say whether the COVID infection precipitated the appendicitis. I can't draw a direct line between the two conditions, but I think they're both common conditions at this moment in time.
Absolutely, doctor. And, anything else you'd like to add? Just, I know that we have heard from our health experts about the concerns going into the holiday season, mostly because families get together and there's more gatherings. The flu season kicks up in higher gear. Is this a good timing for this vaccine finally to get released in November? Do you think that, this will kind of be the incentive for more parents to get the vaccine for their kids? Or do you think there's just still a lot of pushback, a lot of questions, a lot of doubts?
I think there's some doubts. There always will be, right, with a new therapy, despite the sort of what we have thus far as a pretty safe and proven safe track record in other populations, so the adolescent population and the adult population. It's inevitable, right? People are always going to have questions. I think this is probably the best studied vaccine minute to minute, day to day that we've ever seen in the advent of modern science. So I do feel confident that if there are significant adverse effects, we're going to know about them very quickly. Even myocarditis, right? There's been myocarditis and pericarditis reported after every vaccine that we've ever sort of developed. So even that's not that rare. I think in terms of timing, yeah, of course. Any as soon as we get enough data to say that it's safe enough and effective enough, I think that it's reasonable to move forward. I think there are a lot of patients, as probably more parents who are really anxiously awaiting this vaccine and have been anxiously awaiting this vaccine, again, as a way to get back to normal in a thoughtful, as safe a way as possible. I think no one is happy having their children, go to school with, masks and limiting things like sleepovers and indoor play dates and really things that are normal parts of of upbringing. And I think the vaccine is going to offer parents who are anxious about that an additional measure of safety, probably the best measure of safety that we can get, that their child will be protected from the most catastrophic consequences of the COVID infection.
Bonnie has a really good point, and I wanted to bring this up because over the course of the pandemic, we have heard, at the beginning they told us, don't wear masks. This will contribute to you putting your hands on your face more. You might be able to get sick. Then it was wear a mask. And Bonnie's point is very of a good point. She said we heard at the beginning younger children had strong immunity and didn't need the vaccine. Now there's obviously a change where they're recommending the vaccine for children. Can you talk about just in a situation like this, doctor, with this virus, and obviously we've seen the different strains of it, how things evolve, and why do we see these changes that kind of contradict each other?
Well, I think the messaging has been not as consistent as it should have been. I'm not sure that there's been any message from any medical establishment or pediatric body, certainly like the AAP or the CDC or the FDA, or really any individual regulatory group that had recommended against a vaccine. I think that what we saw really is that children seem to be less affected and less severely affected than adults. But again, the experience, particularly that we had in Florida over the last few months, has really sort of disabused that notion that COVID is a disease exclusively of older adults with comorbidities. I mean, the proof can't be any more clear than what our state has gone through over the last few months.
Right. And I know a lot of people have commented on, how long the vaccine has been out and how long these studies have been going for. I know that once the trials began, I mean, the adults who were a part of these trials are still being studied for what, two years, I believe it is. And I believe the children will be the same case. Do you have any knowledge of typically in vaccine trials, how long they study these kids for?
I mean, these patients are going to be studied for years. I mean, for 10 years, you're looking for adverse events. So again, this is the most intensively studied and most intensively critiqued vaccine in human history. So again, I do think we're going to have pretty real-time data as to when and if we're seeing any kind of adverse effects coming up related to the vaccine. Again, I think right now, based on what I've seen as an ICU doctor and reviewing the data, I think the risk of severe disease, hospitalization, this so-called long haul COVID, really outweigh the risks of a potential adverse effect to the vaccine. So I think the risk benefit is in favor of vaccinations at this point.
Thank you so much, doctor. I really appreciate your time. And of course, we'll have more on this tonight at 5 and 6 on Channel 5. You can always get more information on our website, WPTV.com. Dr. Yong Sing da Silva, again, we appreciate your time and have a great afternoon. Thank you all so much for joining us.
You too. Thank you.